Okay, our next speaker is a medical oncologist, Lowell Anthony. We've heard from several distinguished medical oncologists already. Dr. Anthony was with the group in New Orleans for a long time, but a while back he's moved to University of Kentucky, where he's the chief of medical oncology. He has over 2 decades of experience with treating neuroendocrine tumors. He's really one of the most knowledgeable people, with Dr. Wolin and others treating this disease. He was a founding member of NANETS, and we're very fortunate to have Lowell here today to talk to us about the use of chemotherapies in current clinical trials.
Thank you very much, Jim. This is a real honor and a pleasure to be invited here today. I have to say, to be able to address my experiences over the years with such a group is a real honor. And to really honor you, I am attempting not to give a medical technical talk. So if somebody's not understanding something, I want to know about it, because this is really meant to be a discussion with you all. When we evaluate somebody with a neuroendocrine neoplasm, it all starts with the pathologist. Pathologist tells us this person has something that looks like a neuroendocrine neoplasm. This is confusing. It's been confusing since I started attempting to learn what neuroendocrine neoplasms were, because you've got things that are called neuroendocrine tumors, and then you've got things that are called neuroendocrine carcinomas. And we know that some neuroendocrine tumors are benign, but zero neuroendocrine carcinomas are benign. So the reason this distinction is made is that if every malignant neuroendocrine tumor was called cancer, people would be overtreated. So that's the first thing we have to get straight. If they truly do have a neuroendocrine tumor, it will demonstrate on a neuroendocrine, the scan for somatostatin receptor in the majority of the cases, 95% of the time. We're going to see the expression of the somatostatin receptor. If it has elements of the carcinoma, we're going to see a different kind of scan. We're going to see significant uptake on glucose, on radioactive glucose, what everybody knows as a PET scan. Even though these are both PET scans, we have to be very careful when we call our gallium-68 dotatate scan a PET scan, because people instantly want to think, oh, it's radioactive glucose. So we don't try to use the word PET scan when we talk about gallium-68 dotatate. So once that scan is done, then we can start classifying people into what group do we need to start thinking about developing a plan of care. So you can see from the green arrows on this slide how we have things organized over at Kentucky. In the 8 years that I've been there, I've been able to put together a group of about 30 people, and this is updated around July 1, where these people are these patients, their scans, their slides, everything is discussed initially at a neuroendocrine tumor board if they have positivity on the dotatate scan. If not, then they go to the molecular tumor board, where we start looking at things that are now more precision or personalized type medicine, where we are really interested in what those molecular markers may be, and go down a totally different pathway. So the green arrows are going to indicate those patients who have a more indolent disease. In the medical oncology world, we think of somatostatin analog therapy, octreotide, lanreotide. We also consider mTOR inhibitors. We think of tyrosine kinase inhibitors, and we think of chemotherapy. Our surgeons comprise a central role. That's sort of why they're central in that area, and they're with us from the get-go on every case that we see. Our nuclear medicine and molecular imaging people are doing a job of bringing together all the scan data and interpreting that for us. And now in the era of PRRT, we're now able to have a separate review process for people that we think are eligible for PRRT. We like to think that this technology should not just be an individual person's decision, but there's a collective decision, because this is a team, a team approach in delivering care. Interventional radiology, very central to controlling this disease. This is a more indolent disease, so doing local regional therapy makes sense. So, since I've been asked to talk about chemotherapy and its neuroendocrine, there's always this overlap to neuroendocrine carcinoma, because that is where chemotherapy is used, is neuroendocrine carcinoma. That's the backbone. The same way that lanreotide is the backbone for neuroendocrine tumors, cytotoxic chemotherapy becomes the first thing that we do for neuroendocrine carcinoma. If we look at it from a historical standpoint, the interferons was the first agent that Shel Oberg reported on to control carcinoma syndrome, and it got approved in Europe, never quite made it in the U.S. In the 1980s, not only was interferon coming along as promising, but the somatostatin analogs, octreotide was approved in 1988. So my era of training and investigation was right there in the midst of the approval of hormonal therapy. And the fun part of this is I got to go mano a mano on Shel Oberg, because the Europeans were just total interferon freaks. And we, on the U.S. side, could really never figure out how to use interferon properly. We did a trial done at Mayo Clinic, and it was too toxic. I started my first patient at Vanderbilt on interferon. My colleagues saw the patient back in about a month and stopped it. You know, a lot of support I got. And so by about the mid-90s, the Europeans gave up, say, okay, you guys win. It took about 10 years for Shel to say, okay, octreotide should be placed in front of the interferons. So I think this is one place where our FDA, our delay, and all the other stuff got it right, because it protected the U.S., you might say, from all the toxicities of interferon, clearly more toxic than somatostatin analogs. So chemotherapy, 5-FU. 5-FU came about from the 1950s, resulted in a Nobel Prize. It settled into GI cancer in the late 1960s, and it sat there for about 40 years, no advances, and then we finally got oral 5-FU in the form of capecitabine and temozolomide. This is another agent, an alkylating agent that comes to us from the melanoma world, comes to us from the GBM, the glioblastoma world, and it finds its way into the neuroendocrine tumor world. IV, 5-FU, doxorubicin or adriamycin, the red death drug. Streptozotocin, the very first drug approved in 1982 for pancreatic islet cell. And this is a toxin to the beta cell in the pancreas. In medical school, we gave rats streptozotocin to teach us diabetes. So I got to personally witness what happens when you give this to an animal. And then I put in parentheses, because I'm not really going to discuss it that much detail, the cisplatin, carboplatin, topoisomerinotecan that we use as a backbone for neuroendocrine carcinoma. If you notice now, we keep going in terms of the classes of agents that we're using. We've got more and more choices that are evolving for us to use. So now we've gone from chemotherapy, now we have targeted agents. Some people will call these cancer drugs, chemotherapy drugs, okay? And I think that's probably okay, because people think of it like that, but these are not the cytotoxic chemotherapy drugs, so you don't lose your hair. You don't have the typical side effects of myelosuppression and bleeding and the severe nausea and stuff that can go along with the cytotoxic drugs. So to try to distinguish it, I call it targeted agents, because they're targeting specific intracellular pathways. The only problem with this is that these products that we're given are not specific to a single pathway. So on our side of the usage and development, we call these dirty kinases, because they hit a variety of different targets, and they result in a lot of off-target side effects: diarrhea, skin rash, fatigue, hypertension. And there's a number of things that we're used to dealing with these drugs. mTOR inhibitors. mTOR inhibitors came to us from the transplant surgeons, of all places. It was a man named George Thomas that was working with Sandoz at the time and eventually Novartis, who was there in the transplant world and saw that if you inhibited mTOR, it resulted in an anti-neoplastic effect. And if there was a clear champion for the development of mTOR drugs, it would be George Thomas. He clearly took the heat. If anybody can kind of know what it's like working inside a company trying to advance a concept, there are so many naysayers because only about 1 out of 100 products are going to make it, and George is sitting there pushing and pushing and pushing and pushing, and eventually it was approved. Open source radiotherapy. So our radiation therapy colleagues like to think of closed source, where you sit in front of a machine that delivers a beam, the linear accelerator, or you could take I-131 in that general context that's been given for 5 decades or so for thyroid cancer. Open source, you can swallow it, so it's systemic. You don't sit in front of a machine. So with peptide receptor radiotherapy, or PRT, now this is a form of radiotherapy that's targeted, that's being able to give in the vein, and now is a new standard. Immunotherapy. So this is going to have me cross back over to the neurocarcinoma world, because we do have 2 immunotherapeutic drugs approved for high grade with nivolumab for small cell lung cancer and durvalumab for Merkel cell. Okay, hallmarks of malignancy. In the year 2000, Hanahan et al. Just listed some of the characteristics of the cancer cell. So if you had these 6 elements, this would ascribe what cancer is in the body. Chemotherapy agents are going to focus on the division, on the proliferation. So cancer has the brakes off with proliferation, doesn't know when to stop. So what I want to talk about is that aspect of that aspect of the cancer cell that we want to target. The problem with that is you've got the intestinal epithelium, you've got hair, you've got the bone marrow that also is in division and also is taking a hit. So it's not specific. So if we look at the tumor cell and try to characterize all the different potential markers or targets in the cell, and we think of cytotoxic agents, this is going to be number 5 here. We're going to be hitting the DNA dividing. The drugs are going to be targeting that subpopulation of cells. This is the various stages that a cell, whether it's a tumor cell or normal cell, goes through in order to multiply. It's called the cell cycle. And the G0 is where it's resting. The first thing it does is go into G1 or GAP1. Then the replication of DNA occurs, S phase. Then it goes into GAP2, G2, and then the cells separate, mitosis. So our drugs that target dividing cells have got to target one aspect of the cell cycle. What we do know is that these drugs do not target G0. Right there. Worthless. Why would you expose tumors to products that have no target? For your grade 1 neuroendocrine tumors, most of those cells are sitting in G0. It's a problem with apoptosis. It's a problem the cells aren't dying. So if we look at the amount of time that this happens, G0 can last for years. It can last for a few hours. It can last for years. G1 usually is over within 30 hours. The S phase is usually done within 20 hours. G2 is done from 2 to 10 hours. And then the mitosis is done within 1 hour. So this process is well described, well defined. And now we can start understanding how our drugs can potentially be utilized in this phenomenon of cell growth, proliferation. So that the more cells that are in G0, where the Ki-67 index would be low, the mitotic index would be low, considered well differentiated, we call them low grade. Then on the other end, where the proliferative index, the M phase, would be the dominant phase, more than 20%. Mitotic index is high, and frequently either high grade or poorly differentiated, and that would be more related to what we would call carcinoma. The problem that we face as healthcare providers in dealing with neuroendocrine tumors, these tumors don't come labeled, I'm a G1 or I'm a G2, I'm a G3, or I'm poorly differentiated. They don't tell us up front what they are. When a biopsy is obtained, that biopsy may or may not be representative of what we're actually having to deal with. So whenever we look at these tissues under the microscope, when we look at scans, we're always skeptics. We never fully believe what we're seeing, because cancer can morph. It can morph into something that we're not anticipating. We don't know when it might morph. So it's a very wily adversary. So the problem that we face is heterogeneity, and our biopsy may not show heterogeneity, and that's where our scans come in. Unfortunately, we're limited by insurance payments on being able to really do what we feel like we need to characterize the biology on the front end of these tumors. So that's just personal frustration. This just shows what the pathologist is looking at. When they stain these for Ki-67 index, this is a immunohistochemical stain, so it's an antibody that's recognizing an antigen within the nucleus that's expressed when the cells are dividing. So when they're not dividing, and this is the G0, these cells are in G0, these cells would be in M phase, mitotic cells, and so you can see there's a difference between what we would consider a low Ki-67 index and something that is not a low mitotic index. Okay, so that is a background. What are the classes of agents that we use? Alkylating agents came to us from World War II. Bari, to be specific, Bari Harbor in Italy was bombed, was strafed. The U.S. Navy vessels were strafed by the Luftwaffe in 1942. And there was one of the boats that was full of nitrogen gas. The sailors on that boat jumped into a mustard bath of alkylating agents. It was essentially the same as G0, ground zero for Hiroshima. These people, they were on a timetable to die. When they died, they did autopsies. They saw all lymphoid tissue gone. That was the birth of modern chemotherapy. And all this work was done secretly in New Haven at the time. Alkylating agents then became useful in lymphoma and then moved on up into the world of other diseases. Antimetabolites. These are products that have been shown that have come to us from the lab and are now well integrated into medical oncology where they're used. And you can see this very specifically targets S phase, mitotic inhibitors, the potholones, the taxanes will act through inhibiting the S phase, these cells dividing, and inhibits the tubulin. Antitumor antibiotics, doxorubicin or adriamycin, it intercalates between the DNA channels, between the chains, and therefore they cannot separate with that intercalation. The repair enzyme may not be able to be overridden enough to get rid of that intercalation. And then the topoisomerases 1 and 2 are ones that form the backbone for neuroendocrine carcinoma. Okay, so we've sort of explained what the disease is, what the targets are, what some of the drugs that are used. Now, where do we think about using these? So the low proliferative index or low Ki-67 index would be seen in primaries that might come from the intestinal tract, small or large, small bowel, large bowel, colon, pancreas. These are the more common ones. And then we see unknown primary as one of the top 5. In a moderate proliferative index, we can see that these tumors can arise in these organs. So you can see that one's maybe starting in the thymus, in the rectum, might have a little different biology than what some of these other ones are. And then we look at the high proliferative index, and we see again that thymic ones are coming to the surface, and the rectal ones as well have a little bit different biology. And so then how does our agents interface then with the proliferative index? So on the low proliferative index, we have the analogs. We have interferon in Europe approved. And then targeted therapies that focus on VEGF. These are oral tyrosine kinase inhibitors, mTOR, the mTOR inhibitors, and then PRRT. And then on the high proliferative index, we've got the chemotherapy agents we've been discussing. And then you can say, are there times that we use them both? And that's that overlap. That's that part that really has to be understood in detail to understand how those two interfaces come together. When you go back and look at the literature in this area, there's a lot of limitations with it. It's known as a rare disease. It's now about hitting the 200,000 frequent incidents, so that that the NCI, or the Rare Disease Network, is getting close to declaring it not a rare disease anymore. I think within maybe 5 years, it may end up no longer being listed. I don't know if this is good or bad. I guess it's more focused, the bigger the disease is. There's a lot of data on retrospective studies. The methods are very variable. The response criteria are frequently surrogate markers. And the surrogate markers are sometimes just the physician laying their hands in the right upper quadrant and determining how big the liver is. And it almost is hocus pocus a little bit in that regard. So before CT scans, we're very limited on what we could do. Biochemical assessments are evolving and have become better over time. Small sample sizes, and then studies in really high-risk subjects, those who we know are going to relapse. It's just a matter of time. We don't have any guidance with those patients. So when we look at drug development for this, we think of agents that we would develop in phase 1 trials, and I'm going to focus a lot more on this as we go through it. But just to sort of set the tone of where we're headed, the phase 1 and 2 and the phase 3 trials are really the language I want you all to understand when you leave this, to have a good feeling of what we're trying to do. When we see that, now we can talk about how you look at trials. This is phase 2 listing. So these trials are not randomized for the most part, and they're small numbers, and they're not dose finding. So these are trials that are looking for efficacy in specific disease groups. You can look at every one of these and see that the response rate, the middle column, is rather small and frustrating. You look at the toxicity of these agents, and it's quite high. So in the work that came to us from the 1980s into the 1990s, those 2 decades, did not provide us a lot of guidance in terms of using these drugs in G1. And it kind of makes sense. I mean, I lived through a lot of this, and it just doesn't make sense of why you would give etoposide to a tumor type that has no dividing cells in it. Why would you do that? But you had to do it because it was there. That's the most I could come up with. And so that's the sort of history in carcinoma. Now we move up to a primary that's more G2-like. Okay, so pancreatic tumors certainly can be G1. They can be a mix of G1, G2, but mostly we think of pancreas as being more likely to be G2. So now you can see where chlorzotisine and various other drugs that are listed here, dacarbazine, temozolomide, you can, and plus thalidomide. You can see that these are at least prospective and these are retrospective studies. But again, the numbers here are very few, and it's phase 2, and the response rates are very low. Again, these are not this is nothing to really talk about until 2011. This is where it really got exciting, and this is quite a story in my opinion. Robert Fine at Columbia had a laboratory model of where he was developing, looking at the combination of 5-FU and temozolomide in these neuroendocrine cells. He proposed to study this. The problem was the people who made capecitabine, Roche/Genentech, had a mature product. when you have a mature product and the patent's gone, basically, why do you want to invest in it? They weren't interested even in donating the product to a clinical trial. Temozolomide, same kind of story. Schering owned temozolomide. They had already made their money off of temozolomide. Why do they want to invest in it? So Jonathan Strasberg and Larry Coles at the Moffitt thankfully listened to Robert, because Robert came to me too, and I told him I didn't have the infrastructure to do it. I couldn't get the drugs paid for. I didn't have any research funds to collect the data, and so Jonathan Strasberg and Larry Coles put together an institutional protocol in which they did 30 patients and they saw a 70% response rate. What we've learned in medical oncology as I was growing up in the world is phase 2 response rates are always overstated. And MD Anderson, because of the volume that they see, everyone looks at MD Anderson's response rates and no one believes them. But it's just a problem with phase 2 trials. They're done in one center, one group's doing them, and when you break out and you start getting more chefs in the kitchen, things get a little more chaotic. So what our teaching was in medical oncology was that when you see a phase 2 response rate, you cut it in half, and that's the true response rate. So they report this, gets published in Cancer in January of 2011. The pictures that they showed in it were phenomenal, absolutely phenomenal. And so Robert Fine's basic science, his laboratory project, now was panning off in the clinical world. And they did it by letting insurance pay for these drugs. They had no prospective protocol. This is a retrospective study. You'd read it, and it just says that we got permission from the IRB to collect the data. So they ended up collecting the data, publishing the data, and now when they go to the government, because if industry doesn't have anything to profit by a clinical trial, then the government theoretically is obligated to pick up the difference. So when the government was actually asked before they even did this trial, the government said, well, if Roche doesn't donate the capecitabine and Schering doesn't donate temozolomide, we don't have the money to buy it from them. So this trial was not a trial at that standpoint, so no one else could really do it. The results of this trial forced the cooperative groups. We have to now study it. So the government had to cough up the funds. So it was really exciting to see that now we're able to give the update that I'll give in just a second. If we look at randomized trials in gastrointestinal pancreatic cancer, so this would be pancreas and small bowel, you can see that there's a number of randomized trials. And again, these numbers are relatively small. The response rates are not that fantastic. And a lot of these drugs you probably should never hear of, I would hope. Streptozotocin, I don't think I've given that drug in maybe 25 years. I mean, maybe since the rat. I mean, it's been so long. Doxorubicin for this is really a study of toxicity. I don't think I've written doxorubicin for this drug in decades. So it was at our society meeting in June that a practice-changing data was presented. And this is the culmination of what started in Robert Fine's lab in Columbia, New York, to what went through Moffitt, and now is being given to us through multiple centers, through the government support, and now we can adapt our change to what this trial showed. So I'm going to use a technical term here. I don't want to freak anybody out, but methylguanine, I'm blanking, hold on a second, thymidine. So this MGMT enzyme repairs DNA that's alkylated. If you don't have this MGMT enzyme, then you're more sensitive to agents that attack the DNA and can't fix it. So what was shown, when you have this deficiency, you're more likely to respond. And this is some of the background that Matt Kulke at Dana-Farber and other people worked hard on, looking at the mechanism of why this combination should work. The data that was published, you can see here, Cancer 2011. This was 30 patients. Now it's up to 144. Now we look at prospective, randomized, multi-center. This is science. They got randomized 1-to-1. The population reflected pretty much what we normally see. 75% in both arms were Caucasian, greater G2 in the temozolomide monotherapy arm. That was about 55 versus 32% difference, was statistically significant. And then there's a longer time from diagnosis in the combination arm, 34 months versus 24, and that was not statistically significant. So the objective response rate, 28% with temozolomide, 33% with the combination. So that's that 70% that Jonathan reported, cut in half. So we can clearly see that this is one of the highest response rates that's in our era, where there's a lot more difficulty in looking at RECIST criteria than it was in those earlier trials. And even those earlier trials had a tough time getting double-digit response rates. The duration of response is critical here. It's around, let's see, how do I go back here? It's around 10 months with the single agent, 12 months with the combination. The median progression-free survival, so the time that it takes the tumor to grow, to progress, 14 months in the single agent, 23 months in the combination. That was statistically significant. The median survival had not been reached when they reported this in January 2011. After about 30 months of follow-up, it was 38 months on the temozolomide, and it was not reached yet on the other arm. So this is where we are. When we use these drugs in combination, we're going to see more side effects. That's just part of the game. So the grade 3 and grade 4 adverse events are listed here, 22% versus double when you take the combination. So what this means is that the NCI has a common toxicity criteria grading system. Every study that's done in the United States uses those criteria so everyone can be utilized, everyone can be on the same path, same page as it relates to reporting this. So grade 3 are where we really have to hold the drug. We're getting toxicities now that are unacceptable. We have to adjust the dose. We have to adjust the interval. Something's happening there. Grade 4, someone's in the hospital with. So we try to keep grade 3 from regressing to grade 4 in the outpatient setting. The more common ones, neutropenia, 4% versus 13%, nausea, seen more in the combination, emesis, vomiting, more in the combination, as well as diarrhea. Fortunately, these unacceptable toxicities from our perspective is low. The grade 3-4 thrombocytopenia was more frequent in the temozolomide monotherapy arm, 13 versus 8, probably no real difference, but more frequent. And then grade 5 are deaths attributed to the combination or the trial, and then none of those were reported. So where does that leave us with cancer, chemotherapy, or cytotoxic chemotherapy in neuroendocrine tumor/neuroendocrine cancer? Well, we can say that from the data that I've shown you today, that it's established in these tumors that have a moderate Ki-6 index. They have a moderate number of cells in mitoses, moderate number of cells that are not resting. And that happens to be in the gastroenteropancreatic. We have capecitabine, temozolomide, Cape-Tem. Historically, 1982, streptozotocin, these other agents I'd like to think are historical and not of any real value today. The poorly differentiated ones you can see listed here. Some of the problems, and this is what keeps us going, keeps us waking up in the mornings, is we're not curing anybody. And we're not surgeons. We want to be surgeons, but not do it in the operating room. So we want to improve our therapy. We know we have a long way to go to crack this puzzle. Non-curative equals palliative equals control in many cases. And that's one of the real limitations that we have. But if we can turn this disease into diabetes, insulin is not curative for diabetes either. So that's some of our challenges in a disease that doesn't grow very fast, that our job is to control it, cure at all possibility, and then not harm for those that we cannot cure. Refractory disease, this is the part that we're always looking at. If you look at the data that came to us from the Lutathera trial, 1 out of 5 patients had no benefit, 20%. Zero benefit. And they got 4 doses of a radioactive substance and had no benefit. I don't want to commit that in my practice, I don't want to be administering a $50,000 drug 4 times and have no benefit. We've got to figure this out, and that's one of our objectives at our center, is to figure out who we should not give it to just as much as we figure out who do we need to give it to. Therapy after surgery when all visible disease is removed. So we call this adjuvant therapy. We don't have any guidance on how to use therapies after surgery when we know it's just a matter of time these tumors will come back. So those are some things that we'll probably not answer in any near future. So this is something that I commonly encounter in my practice. I think I'm probably guilty. I think anybody that wants to reach out and look at alternative approach, we have integrative medicine, complementary medicine. So because when it actually works, they just call it medicine. So if it hasn't been proven to work, what is it? Religion? It's something that you want to believe in. And if you want to believe in it, then you can put your money behind it. But the first thing that I think of when I think of these kind of approaches is, where's the evidence? I think the citizens from Missouri got it right. It's the show me state. Show me the data, and then I'll show you my credit card number, right? Okay, how do we translate leads? How do we translate what Robert Fine observed in his laboratory? How do we translate that into what we saw in E2211, that randomized prospective clinical trial that was practice changing, started off in someone's laboratory? What's really interesting is that since that trial was not pushed by a drug company, we won't have a label, a change of the label of capecitabine or temozolomide, because the companies didn't pursue those changes in labels. They didn't pay for it, and they don't get it. So in our area, capecitabine and temozolomide will always be, quote, off-label. But there's so much evidence for it, and the NCCN guidelines, everything will kill any insurance company that says, where's the evidence here? Just because it's not in the label doesn't mean it doesn't work. So what are clinical trials? Clinical trials are really why I'm standing up here today talking to you, because when I entered training, it was the clinical trial of octreotide and carcinoid syndrome that gave me my opportunity to define the rest of my career. Now, did I know that at the time? I had no idea that that was going to happen to me. But I can tell you, growing up in the medical world in that era, everything was cisplatin. Larry Einhorn had reported what cisplatin had done in testicular cancer. Therefore, cisplatin had to be used in every cancer. So I came up as an intern admitting all these people to the hospital for hydration therapy so their kidneys wouldn't get knocked off with the cisplatin. When octreotide came along, wow, this was the opposite. Instead of drugs that are highly toxic, now we've got drugs that are peptides. And the pressure I felt when I switched over from being a cytotoxic investigator to more of a peptide investigator, it was the same pressure that our neurosurgeons felt when they made the transition from bloody neurosurgery to bloodless with Gamma Knife. Because, you really aren't part of us. If you don't do neurosurgery that involves blood, you're not a real neurosurgeon. If you're not a medical oncologist that's giving cancer drugs, makes people hairs fall out, and give them grade neutropenia, grade 4 sepsis and stuff, then you're not a real medical oncologist. So as I transitioned in the 1990s to hormonal therapies, patients would actually hug me in the clinic. That never happened with the cytotoxics. They would throw up if they saw me in the grocery store. So it's these clinical trials that got me started. And one of the things that was dogma, I wanted to disprove dogma. The dogma that got me started in the clinical trial was, if you gave too much octreotide, you would make the body's endocrine systems collapse, and they would die from life-threatening fatty acid deficiency. Oh, really? This is what I was told. When I looked at the data as a junior faculty at Vanderbilt, I said, I don't know. I had patients that took accidentally 5 times the amount, and they seemed to feel better. And I was warned, oh man, you got some liability on your hands here with these patients that overdose themselves. And so those 3 overdoses pushed me to do a phase 1 trial. In 1988, 89, in that time frame, when Sandoz launched sandostatin or octreotide, I went up to the product manager in Miami, and I told her that it was time to do a phase 1 trial. Can you imagine going up at the very end? This company has finally got a new agent approved, and now someone's coming. We've got to start all over again. We don't have any idea about the dosing. And she thanked very much, and you were someone just to push away. So the tenacity of what happened in my patients were such that I kept pushing beyond her, got to the right people in Sandoz, and eventually the person that made the decision, his father had carcinoid, and he, let me do it. So I went on and did high doses of octreotide, and I proved that the endocrine system doesn't fall apart. I proved that the gut does not release all the fat that it's given. And so all this stuff that I was told, what's the maximum tolerated dose and what's the toxicity, was all off the board. So we never got to the highest dose of octreotide. So it's probably one of the safest drugs we use. It's active in micrograms, and it's active in milligrams, and it's non-toxic if you give it up until the time it starts precipitating out of the bloodstream in the animals. So the highest doses was been given by the NIMH to patients where they're trying to drive the drug across the membrane barrier, the CSF barrier, the blood-brain barrier, and just to see what that differential was. So it's these ways that we find new ways to prove, and it's the final step. E2211 was the final step of looking at what was happening in the cells to these chemotherapy drugs. Now, if you get on clinicaltrials.gov and you type in neuroendocrine tumors, you're going to get a lot of hits. You can look at the global. Global's going to blow your mind how many studies are out there. When you look at the U.S., you're going to come in around 400 or 500 studies are out there. You can see where the big population centers are. The states that are in red have the most number of trials open. But I think you can see every state in the union is represented, including Alaska and Hawaii. So the research is out there in this, quote, rare disease. To go back to what I introduced earlier, a phase 1 trial is where we don't know the dose. So it's a dose ranging trial. So it's really a toxicity trial. And these are trials that are more likely to help other people than to help the person getting it statistically. So you don't need very many people to answer that question. The phase 2 trials is what I mostly reported on today. I reported on some phase 3, but phase 2 is where you've got what you think is an active dose, and you're going to see whether you got a tolerable dose. You're trying to see if it's active or not. So you're trying to match activity and toxicity, and then go forward with the phase 3 if it looks promising. So the phase 3s are the big ones. Those are the ones that have to get out into the big centers. So the phase 1s can be at a single center and get them done. Phase 2 can be a few centers, and then the phase 3 have to be thrown out to the masses. So you can kind of see that the results of phase 3 are not going to be quite as good as phase 2 because there's less control over the variables. The problem with phase 3 is that by the time you accrue 400 or 500 people to a randomized prospective trial, the standard of care has changed. And this is very frustrating because it might take you 3 to 5 years to accrue that many, and then people start losing their interest in it because, PRT's here. Why do I want to be putting people on capecitabine and temozolomide versus temozolomide when I've got PRT? They might get an inferior treatment. So you can see there's a lot of conflicts when care providers are trying to decide what the next step might be in someone's care. I think from a patient perspective, what you need to know is why are they approaching you? What's the purpose of the trial that you're interested in? Why are they doing it? What should be the treatment studied be better? Why should it be better? And why maybe it not might be better? Ask the question both ways. And then, how long are you going to be in the trial? What's the minimum, the maximum? How's this long go on? Is this like insulin and diabetes? What's this all about? And then what kinds of tests and treatments might be involved? And I think this is some of the exciting aspects of clinical trials, because what happens in a clinical trial are things that you normally don't do as standard of care. So you'll do EKGs, you might do echocardiograms, you might do things that you find things that sometimes you say, I don't need to know about, but you need to know about them if you're looking at safety signals. So we have to get those kinds of data. So you really learn more about yourself by doing extra stuff. By participating in a clinical trial, it becomes sort of some things become more revealing in terms of what is happening. What kinds of tests and treatments, how will you know if the treatment's working? And I think these are all things that the investigator and the care team should be able to answer. How will I be told about the trial results? Okay, so you spent 10 months of your life in it. What happened? Am I ever know? How do I ever find out? How long do I have to make up my mind once I've been approached to joining a trial? How long do I have to, is this high pressure sales? I got to tell you right now. Or can I wait a month? What's the deal? What do we need to do? Who can I speak with about questions that I have during and after the trial? I want some sort of contact. Who's going to be in charge? I want to know a name. I want to know a phone number. I've got to have some contact with the sponsor that's taking care of my care, that's taking care of the trial. Is there someone I can talk to who's been in the trial? I find this to be a very helpful question when people are trying to understand if it's right for them. And I think here, what are the possible side effects or risk of this new treatment? And this comes to us from that early data. So depends on what kind of trial and how many people have been done. This can be very specific, and also it can uncover new side effects as well. What are the possible benefits? How do the possible risk and benefits of this trial compare to those of just standard of care? Why is it? What's the potential? And then when it starts getting into healthcare information, how will my healthcare information be kept private? And so this is where institutional review boards are very sensitive to these issues. And then what happens if I decide just to walk away? I've had enough. Questions about cost. Will I have to pay for any of the treatments or tests? A critical question. What costs will my health insurance cover? Who pays if I'm injured? Who can help answer any questions from my insurance company? Questions about daily life. How could this trial affect my life on a day-to-day basis? How often will I need to come to the hospital or clinic to be assessed? Will I have to stay in the hospital during the clinical trial, or is it all outpatient? If I do have to go in the hospital, how long? Will I have to travel long distances? Will I have checkups after the trial's over? What will happen? And then comparing choices. I think this is really kind of comes to where we really have to address these things. What are my other treatment choices, including standard care? So when I go up before our IRB about any trial that has my name listed on it, this is one of the very first questions they ask me. If you were not doing this trial, what else would you be doing? And they will not take nothing. So you just can't give them a pat answer. How does the treatment I would receive in this trial compare with the other treatment choices? So now you're really weighing the pros and cons of what if I do the trial, what if I don't? Maybe I'll wait and do the trial a little bit later. And those questions will come to surface in terms of saying, what if I want to wait 6 months and think about it again? What will happen to my cancer without treatment? Again, a critical question. We think of side effects of cancer drugs, but we also have to be thinking about side effects of the disease. So for this last few minutes, I wanted just to take some time to discuss with you some specific trials that are ongoing and to be as objective as I can be. These are 5 trials that are being sponsored by the National Cancer Institute, so I have nothing here to promote as a specific site or investigator, so I want to be as fair about this as possible. So what you're going to find when you go on and try to look for clinical trials, you're going to find them classified according to grade. So neuroendocrine tumors with grade 1, there's a cabozantinib, S-malate, in treating patients with neuroendocrine tumors previously treated with everolimus that are locally advanced, metastatic, or cannot be removed by surgery. So the first thing to say to yourself is, what in the world is cabozantinib? Well, actually, this drug is on the market for another disease, so there's a lot known about it. This is a drug that's a TKI, or tyrosine kinase inhibitor. It targets specific tyrosine kinase receptors, so these are specific pathways inside the cell, cancer cell and normal cell, that when those pathways are blocked, it will influence tumor growth. So this would be in the same class as, let's say, sunitinib, that's approved in pancreatic. So that would be considered a tyrosine kinase inhibitor. So now the next question is to say, what's the purpose of this trial? Well, it's a phase 3. That means they're going to go after hundreds of people. They've got 191 locations. That implies it's probably outside the U.S. This is probably more global to get that many. So you can see that there's a lot of money behind this. There's a lot of energy. They want to get it done quick. They want an answer. So you can see this is a high priority trial. So they're going to be comparing the cabozantinib to placebo. Now that is always tough in my book. When you go to somebody, their disease is progressing, and you say we're going to let a coin toss determine whether you get active drug or not active drug. So this is one of the difficult times, I think, when you talk to somebody. The question that comes up immediately is, well, when will you know it's working or not for this disease? 3 months. Then what can I get the drug if it doesn't work? So this is sort of where the investigator has to settle a person down, saying, if there is some progression in you, it's not going to harm you. Then if you feel comfortable with that, then you would feel comfortable going on such a trial where there's a placebo arm. If there's a lot of disease there, a little bit of progression can't be tolerated, then this is not the trial for you. Another trial. This is a product, PIN 221, in somatostatin receptor 2 expressing advanced cancers, including neuroendocrine and neuroendocrine carcinoma, small cell, the poorly differentiated. So this is a very aggressive trial looking at all subtypes and doing it in a phase 2. They don't need very many centers. These will be 6 of the NCI designated centers doing this. It's open label. Everybody knows what they're getting. It's a phase 1/2A, meaning that they're doing some dose finding, and then once they find that dose, they're going to keep that dose going in a larger number of people. In order to qualify, you have to show expression of the somatostatin subtype 2 receptor. These would be people who had tumors in the intestinal tract or pancreas, lung, or thymus, or neuroendocrine tumors, or small cell, large cell. This is a fairly broad trial, and it should accrue quickly. We should have answers for this product in a quick, short amount of time. Another trial, ribociclib and everolimus in treating patients with advanced well-differentiated neuroendocrine tumors of foregut origin. Again, notice that they're using foregut to get a homogeneous group of people, as homogeneous as possible. So this product, ribociclib plus everolimus, this combination may stop the growth of tumor cells by blocking some of the enzymes that are needed for cell growth. It's a phase 2. So this means that it's going to be something under 100 subjects needed, meaning that it'll go pretty quick. And they're looking at this combination in well-differentiated neuroendocrine tumors to treat those that arise in the foregut, pancreas, lung, we consider foregut, that have spread to other parts of the body and usually cannot be cured or controlled with treatment. Again, this will be an exciting study to look at the outcome. Well, a lot of things that are happening in medical oncology is not happening with cytotoxic chemotherapy. I don't know of a new cytotoxic agent that's in development. It's just the energy, the excitement is not in what came to us up until the year 2000 or so. Irinotecan was probably one of the latter ones. We just don't have a lot more in the world of neuroendocrine carcinoma. So this is a trial. Now you can start thinking about, this G1 is listed there as G1. And they're looking at a combination of a platinum with etoposide, with or without vandetanib, in treating patients with previously untreated extensive stage small cell or high grade of plurally differentiated neuroendocrine cancer. So this is technically not a G1 unless their title doesn't really incorporate that, but under the NCI listing, they list it as a G1. It's a study that's only been done in 2 locations, so you can kind of see they're trying to control the collateral damage if it doesn't work or whatever. They're trying to try to not have it out there too broad until they start getting some signals that it's useful, and then they'll put it forward. But what the concept here is that they want to use chemotherapy drugs to use that in combination with vandetanib to see if they can do a better job in controlling the disease. And they've done the right control in terms of looking at it with or without the intervention. And then the last one I'll mention, this is another tyrosine kinase inhibitor. It would be considered a dirty kinase. This is regorafenib. It's considered third line in colorectal cancer. Is active in GI stromal tumors, is active in hepatocellular cancer. And so now the question is, can we use regorafenib in treating people with advanced or metastatic neuroendocrine tumors? So this is a phase 2 trial studying regorafenib in patients with neuroendocrine tumors that have spread from primary site to other places. And it may stop the tumor growth by blocking these enzymes, the tyrosine kinases, that the cells depend on in order to grow. So, where do you go from here? I think a good place to start, the easiest one is just ask your care providers at your center what are at the right time. So, clinical trials are thought of when standard of care is not available. There's nothing left in the standard of care. And the person that knows most about you can do the directing of traffic. A lot of times, family members will want to jump on and start looking at what possibilities are. And clinicaltrials.gov is a good place to start. Not the only place, but it's a good place to start. These trials are ones that it may be difficult to really find what you're looking. There's so many of them, you might get lost in it. But they're on advanced search. You should be able to go down to pretty much those within an area that you live in that's reasonable for you to inquire about. So I just like to leave you the fact that when you look at your motive for this disease, the zebra, these stripes are really their biometric identifiers. And just like there's really no 2 zebras alike, then there's really no 2 patients that are alike. And their treatments should not be alike. And we, I think, as a multidisciplinary care team, are depending upon everybody as part of that care team to assist us in getting it right on the very beginning, that we're not finding out a year later that we misdiagnosed the circumstances. So our job is to get it right on the front end. So I'll just stop right there.